Yes, sir.
So it's good to start with the case always. So case one is a 42-year-old man who comes to the medicine clinic. So his chief complaints are constant burning pain and paresthesia bilaterally from his feet to knees for 3 to 4 months. He also mentions feeling excessively thirsty and also says that his clothes fit more loosely now. Now, there is no marks for guessing that obviously the case is of diabetes mellitus, but of course there are these constellation of symptoms which are actually pertaining to all the organs in the body, basically. So constant burning and paresthesia pertaining to nerve. So there is some kind of neuropathy which is happening with the patient. He's feeling excessively thirsty, meaning the patient has got there is loss of water in the body, so he's having polyuria and polydipsia at the same time. His clothes are fitting more loosely. That shows that obviously there is kind of weight loss, and there is a role of adipose tissue. There is lipolysis going on in the body because of this diabetic mellitus. So, so diabetes mellitus is a multi-system disorder, and now I would like to show you this slide that how diabetes mellitus and Hippocrates, who is the actually the father of medicine, who was first to diagnose diabetes mellitus. So he presented this classical triad of diabetic symptoms, which are polyuria, polydipsia, and polyphagia. So this clinical approach was almost followed since the last 2,500 years, which moved now into the 20th century, and more sophisticated tests are being used to diagnose diabetes and obviously to monitor and control it. First, the glucose tolerance test and then the glycated hemoglobin, which we'll see in the subsequent slides. So as I already mentioned that it is not a simple disease, it is a syndrome. It's a group of metabolic disorder involving the carbohydrate metabolism, in which the glucose is underutilized and obviously overproduced because of insulin absolute or relative deficiency, and which results in hyperglycemia. So this is a very simple diagram to show how there is absolute and relative insulin deficiency, which actually leads to increase in the counter-regulatory hormones in the body, which causes lipolysis in the body. There is dissolution of the fatty tissue, leading to generation of free fatty acids and glycerol, which are utilized by liver to generate a lot of glucose. Again, there is a muscle breakdown which is happening in the body, causing release of the proteins, and these proteins in the form of amino acids and lactate are used by the liver to make glucose. So glucose is increasing in the body. There is hyperglycemia. It is not being utilized, and then obviously hyperglycemia causes osmotic diuresis, leading to volume depletion, hypoperfusion, loss of electrolyte, leading to acid base disturbances. And also at the molecular level, a lot of things are happening. There is reduced nitric oxide. Nitric oxide, as we know, that the function is vasodilation, so there is vasoconstriction which is happening. Superoxide generation leading to free radical generation, endothelial dysfunction causing atherosclerosis, platelet activation again causing a formation of thrombotic tendency in the body, immune dysregulation is happening at the same time, and mitochondrial injury, which actually sums up why there is sepsis, multi-organ failure, and finally mortality in these group of patients. So this is the simple classification of diabetes adopted by the American Diabetic Association, which classifies diabetes into four major categories: type 1, type 2, different specific subtypes, and the gestational diabetic mellitus. Now, type 1, as we know, it was conventionally called as the NIDDM, which is due to autoimmune destruction of the pancreatic islet B cells, causing absolute deficiency and inability to secrete insulin. Type 2, which is the most common form worldwide, seen in almost 80 to 90% of the patients, combination of insulin resistance and inadequate insulin secretion. The third type is gestational, which happens during pregnancy, seen in almost around 17% of the pregnant ladies. Obviously, it is a self-limiting kind of illness, but it is a major risk factor for the development of type 2 diabetes in later life. And then there are some rare varieties which are monogenic subtypes, which are actually involving a single gene, a autosomal dominant gene, which is inherited from one of the parents. And then we have some combinations of these diabetic mellitus disorder, which are actually overlapping between the type 1 and type 2 diabetes, which share characteristics of both. And owing to type 1 may have some metabolic characteristics of type 2, owing to a lot of sedentary lifestyle which is happening currently and increased obesity. So coming to the case again, we know the history now. So the hemogram, can someone please interpret the hemogram for me?
Uh, Hemoglobin is 12.3 gram per dl, which is
Yes.
normal, मतलब lower side. Then RBC is 4.5 million per microliter, which is also on the lower side. And WBC is 8.86 into 10.3 per microliter, which is also in normal. Platelet is also normal. Um, yes, normal. MCV is 88, which is normal. MCH is 29 picogram, which also comes into normal range. And MCHC is 32.10 gram per dl, which is also normal. RDW is CV12, which is also normal. So this picture is normal.
Yeah, so actually when you see this hemogram, so hemoglobin is 12.3, which is actually low for the
Yes,
age
sir.
and
Yeah.
gender of the patient. So he has anemia. The hematocrit is normal. So can you tell me the relationship between hemoglobin and hematocrit?
Yes, sir. It should be 3 times.
Very good. So it's 3x. So three times the hemoglobin is the hematocrit, which is actually here also it is seen clearly. So the
Yes.
RBC is normal, WBC is within normal limits, platelets are normal, and the RBC indices and the RWCV is also normal. So from this picture, it looks like there is anemia in the patient. And which type of anemia?
So normocytic, normochromic.
Correct. So excellent. So it's a normocytic normochromic anemia from the hemogram, from the automated hematology analyzer, which we have received. Now coming to the differential cell count. So you can see that I usually follow the absolute count of all the differential
Yes.
as against the percentage. So percentage may be misinterpreted because it is relatively high. But so WHO states that you have to always follow absolute counts of all the differential cells which are there in the urine. So can you interpret this,
So
please?
absolute neutrophil count is 5,600,
Yeah.
which is normal. Absolute lymphocyte count is 2,400. Absolute eosinophil count is 170 per microliter. And absolute count of monocyte is 590.
Yeah. So
Absolute count of neutrophil is 30.
yes. So you can see that if you summarize this, anemia, which is normocytic normochromic type, with differential count being absolutely normal,
Yes,
right?
sir.
So next is the blood film. Can you quickly tell me what is happening in the blood film and why this lymphocyte is placed here?
The lymphocyte is placed for the comparison of size of RBC,
Correct.
which is
Yeah.
which is
So
smaller.
lymphocyte is placed actually, the nucleus of a small lymphocyte is important.
Yes, sir.
So if the nucleus of a small lymphocyte is the comparator of the size of RBC. So if it is equal to the nucleus, then it is normocytic.
Normocytic, normochromic.
If it is less, then it is a microcytic type of RBC. So here you can see this. These are the platelets which are shown by this arrow, and the arrowhead shows the lymphocyte, and this dotted arrow shows the central pallor which is in the RBC. So central pallor should be how much,
One
Dr.
third.
Simran? Yeah, so it should be less than one third normally. So here you can see more or less it is less than one third only. So your CBC the automated hematology analyzer CBC and the peripheral blood findings are matching. So it is a type of internal quality check which is happening. So it is a correlation check, which is okay,
Yes,
right?
sir.
So moving on. So what is the description? So it's a
Normocytic normochromic RBC with few microcytes
yeah.
also
So it's a
seen.
predominantly normocytic normochromic with a few microcytes also seen. WBC count and morphology appears predominantly normal. Platelets are adequate in number and morphologically fine. There are no gray platelets, and obviously there are no hemoparasites or atypical cells in the smear examined. And so impression is a normocytic
Normocytic
normochromic anemia.
normochromic.
So would you advise anything?
Um, Serum iron can be advised few
Correct?
micro on view of few microcytes
Yes.
and
So good, yeah. So you can advise your serum iron profile, which regularly constitutes the serum ferritin, TIBC, transferrin saturation. Those are very important parameters. And then you can also advise serum transferrin receptors, which actually differentiates iron deficiency from anemia of chronic disease.
chronic disease.
And then you can also do a erythropoietin
Erythropoietin.
level of the serum, right?
Yes, sir.
These all investigation you should advise. Yeah. So, to summarize, a patient of diabetes mellitus coming to the medicine clinic with those constellation of symptoms with anemia, morphology of WBC is absolutely normal, platelets fine. So, impression of the blood film was a normocytic normochromic anemia, which we advised as a serum iron profile, transferrin receptor, and erythropoietin levels estimation in the serum, right? So, when you see the literature review, so anemia is one of the most common and the most prevalent blood-related disorders that occurs in patients with diabetes. And actually, it is more commonly seen in patients who have renal impairment because
Erythropoietin deficiency is there.
yes, so juxtaglomerular cells which are located in the kidney, they produce erythropoietin. So, which I think will be covered by Madam Dr. Geetika in the upcoming slides. So, erythropoietin is very important hormone which maintains the RBC level in the body. So, if this causes this deficiency of this, yeah. So coming on to the biochemical findings of these patients. So you can see the renal function tests like creatinine is deranged, right? So it is on the higher side, 1.3. So it correlates with the renal impairment. That is why the patient is having anemia. Uric acid is all normal. The ALT, AST are perfectly within normal limits. So, and these are the other investigations which were done for this patient. So, glucose fasting is 185.40, and hemoglobin A1C, which was done, is 10.86%. So, clearly, this patient is classified as a diabetic mellitus type 2 patient. And so, what is the WHO criteria of classification?
The fasting glucose should be more than 126
Yes.
and HbA1c should be more than 6.5%.
Mm-hmm.
Postprandial should be more than 200 mg per dl.
Correct. So this is the recent American Diabetic Association guidelines, which say that these are the four criterias: hemoglobin A1C more than equal to 6.5%, or fasting plasma glucose of 126 milligram per deciliter, 2 hour plasma glucose more than 200 during an oral glucose tolerance test, or in a patient with classical symptoms of hyperglycemia or hypoglycemic crisis, a random plasma glucose of more than
More than
equal to
200.
200. Yeah. But there are some disclaimers down. So, in the absence of unequivocal hyperglycemia, you require diagnosis requires abnormal results on two different tests, that is glucose and HbA1c on the same day, or two abnormal results from samples obtained on different days. Correct? मतलब कि अगर किसी में हाइपरग्लाइसीमिया ठीक से नहीं आ रहा, then you have to do two tests of glucose estimation. First is can be the fasting glucose or hemoglobin A1C on the same day, or two abnormal results from the samples obtained on different days. That will also suffice. Then the test should be performed in a laboratory using a method which is a NGCP certified, which is National Glycohemoglobin Standard Program. or standardized to the DCCT assay, which is the diabetic control and complication trial assay, right? And then they also say that point of care assay should not be used for diagnosis of diabetes mellitus. And what does fasting means? Fasting means that no caloric intake for at least 8 hours should be there. And here they have mentioned OGTT. So what is OGTT? As defined by the
Tolerance test.
WHO?
The oral glucose tolerance test. So 75 gram of glucose is given to the patient, and
Yes,
after 2 hours, blood glucose is measured.
correct. So
It should
absolutely.
be
So
more than
this is
200.
the definition of OGTT, which is there. And when we say random blood glucose, we mean that any time of the day without regards to time since the previous meal, right? So these are the guidelines for the diagnosis of diabetes mellitus. Moving on, how to interpret a 2-hour OGTT. So WHO has again given the guidelines which are there at 0 hours and 2 hours, and these are the levels. So impaired fasting glucose more than 126, at 0 hours 140, impaired glucose tolerance of 126, and then 2 hours between 140 to 200. And this is the diabetic range which is there. More than 126 at 0 hours and more than 2 hours, which is 200. So, can anyone mention, is there any pre-analytical issue which, with regards to estimation of diabetes, which should be taken care of? So, first of all, the fasting. The fasting issue has to be dealt properly, right? So, overnight fasting means fasting of at least 8 hours. And इसका मतलब है कि patient will not have any food for 8 hours, but he may consume water. So this has to be a clear-cut instruction from a laboratory physician that these tests are very sensitive, and obviously the fasting needs to be taken care of. Then various studies have indicated that there is variation of fasting plasma glucose diurnally, meaning that the fasting plasma glucose is higher in morning than in the afternoon, indicating that if it is done in the afternoon, you may miss actually quite a few cases of diabetes. So that is why guidelines are there which say that the fasting plasma glucose are done in the morning. Then there is an issue with regards to vial also. So when you actually take blood sample from a diabetic patient for estimation of glucose, so everyone knows that we use a gray top vial, which contains
Uh,
which chemical. It contains sodium fluoride, right? So sodium fluoride is a chemical which is there in the gray top vial. So when the patient sample is being taken in the gray top vial, the glycolysis is happening ex vivo, because the RBCs and the WBCs, they are using the blood sugar. So actually the blood sugar is being depleted. So you may have a spuriously low blood sugar estimate of the patient if you don't take care of the chemical which is there in the body, in the tube. So to minimize glycolysis, a tube containing a rapidly effective glycolytic inhibitor such as granulated citrate buffer should be used for collecting the sample. Or the sample, when it is isolated from the patient in the tube, it should be kept in ice water slurry, so that there is no the glycolysis process is stopped, and it should be immediately subjected to centrifugation to remove the cells at 3000 rpm for 15 to 30 minutes. When we use tube with these inhibitors like sodium fluoride, they are actually not reliable to prevent short-term glycolysis. This has been proved in many studies. And so this in various studies it is mentioned that glycolysis continues for up to 4 hours in samples containing only fluoride, but after 4 hours the glucose concentration is stable for at least 3 days at room temperature in the presence of fluoride. So short term glycolysis cannot be taken care of by using a gray top fluoride tube. So is fluoride the ideal chemical for blood glucose? Actually, no. So there was a study by Gambino R. et al., which showed that acidification of blood using citrate buffer inhibits in vitro glycolysis far more effectively than fluoride. And they demonstrated that the mean glucose concentration in these samples at 37 decreased by only 0.3% at 2 hours. So the results are in front of you that the glycolysis is stopped by using a simple citrate buffer, which is a low ionic solution, which causes inhibition of the glycolysis phenomena ex vivo. And then 1.2% at 24 hours when blood was drawn into tubes containing citrate buffer. So this proves that we should actually use a citrate buffer with fluoride to inhibit short-term glycolysis. But actually these things are not very practical, and in day-to-day life it's very inconvenient to use these things in your daily practice. Yeah. So we have discussed about case one. So to summarize, so man in the fifth decade with a constellation of symptoms which are were of classical diabetes. We saw that the CBC had shown normocytic normochromic anemia. The renal function test in terms of serum creatinine was deranged. The blood glucose levels were abnormal, and there was deranged hemoglobin A1C. We also discussed about pre-analytical issues which can be pertaining to the vials, pertaining to the with regards to diurnal variation of the patient's samples, and also we saw that how can we improve the quality of the vials when we are estimating blood sugar in diabetic patients. So before moving on to the next case, are there any questions for me
No, sir.
at this point?
No, sir.
Okay. So can we move on to the next one?
Yes, sir.
Yeah. So moving on to the next case, a 68-year-old man who retired from an office job with government comes to the emergency clinic with a delayed wound healing from an injury to his great toe that occurred 2 weeks back. His only other problem is hypertension, which is actually treated with a small dose of ACE inhibitor. And he quit smoking 20 years ago. He has no problems with regards to his lipid profile, and the stress ECG, is done every 2 years, is normal. He is a non-alcoholic. Yeah. So this is the hemogram.
So the hemoglobin is 12.1 gram per deciliter, so it is slightly on the reduced side, and the HCT hematocrit is 38%, which is also slightly reduced, and the RBC volume is 4.46, which is of at the range, I mean minimum level. Then the WBC count is 13.92, 13,000, that is increased. Platelet is 87,000, so platelet is also decreased. MCV 89 FL, that is on normal level. MCH is also normal. MCHC is also on normal level. So interpreting this, he is having mild anemia, increased leukocytosis and thrombocytopenia, decreased platelet count.
Yes, yes, perfect. So, and what about this differential count?
So differential count of neutrophils is around 9.9, that is of increased neutrophils. And absolute count of lymphocyte is of normal level 2.6, and eosinophil 0.17, that is also on normal level. Monocyte is actually, mild increase is there, 1.2, basophil 0.05, which is of normal range. So he is having, in differential count, he is having neutrophilic leukocytosis,
Yes, very
as
good.
well as,
So if we just summarize, so he's having anemia. Yeah,
yes,
hematocrit
yes,
is
sir.
decreased.
Yes, sir.
You have leukocytosis, which is monocytosis, which is composed of monocytosis and
And
neutropenia,
neutrophil.
and there is thrombocytopenia,
Yes, sir.
right? So in a diabetic, considering this diabetic patient,
Yes, sir.
and with this profile, what will you think?
He's having some acute injury.
Correct.
Isn't
So
that all these
history is
parameters?
acute injury. Yeah. So acute injury with a delayed wound
Delayed
healing.
wound healing. Yes.
Yeah. So these are the soft pointers from the history. He comes to the emergency clinic and he's hypertensive on medication, and rest of the history appears more or less unremarkable. So the positive
Yes.
points are he's a man in the seventh decade, injury to the great toe, and
Delayed wound healing.
this sort of hemogram.
Yes, sir.
So what will you think? Any other suggestions from anyone? Okay, so this is the blood film. Can you describe, Dr. Safis?
Yes, sir. The RBCs are normochromic, normocytic RBC same. WBCs increase the number with a lot of neutrophils.
Yes.
Sir, and
Why do you say these are neutrophils?
they are 2-lobe, 3-lobe nucleus,
Right.
and they're actually bigger than RBCs.
Mm-hmm. Correct. Right. So these are your neutrophils, and can you see there's some
Band form,
this neutrophil is,
hypersegmented
yeah, hypersegmented neutrophils.
neutrophil. Yes, sir.
So hypersegmentation do you know the criteria of hypersegmented neutrophils?
If there is one 6-lobed
Yeah.
hypersegmented neutrophil, then that is characteristic for megaloblastic.
Yeah. So hypersegmented neutrophils can be seen in a lot of conditions, from macrocytic anemia, sometimes in severe iron deficiency also, sometimes in leukomoid reactions also. Yeah. So this, yeah. So the definition you said is absolutely right. So one neutrophil with 6 lobe, or at least 3% neutrophils with 5 lobes. So yeah, in this smear, we can see that it is a normocytic, normochromic blood picture. Neutrophilia is there. Platelets are the platelets are basically less, 87,000 from the count, and but the morphology is normal. So there are no gray platelets or anything, and no other abnormal atypical cells are seen. So these are the biochemical findings. So creatinine is 1.1, normal, very good. Urea,
Urea is increased.
urea is actually not increased; it's within normal limits. Mm-hmm. Uric acid,
Normal level only, so.
normal. Your liver function tests,
ALT, alanine aminotransferase is normal only. Aspartate is slightly increased.
slightly increased. What other investigation would you suggest now, considering this scenario? Anything which comes to your mind? You said that there is neutrophilia, right, with monocytosis in a patient who is diabetic with delayed wound healing.
Sir.
So neutrophilia signifies what? And monocytosis also.
Acute inflammation.
Yeah, acute. Very good. So acute inflammation is there. So which biochemical marker will help you to actually prove your case?
ESR, CRP.
Correct. So CRP,
Yeah.
C-reactive protein, was done in this case. So in this case, it was 50.5, and normal is less than 0.3. So obviously, it is markedly elevated, and it signifies there is some kind of infection which is going on.
Infection.
Yeah. And then for infection, which investigation do you do? Which microbiological infection do you do? Investigation. When there is infection in the body, what do you take from the patient? Yeah. So blood culture has to be taken, right? So blood culture was done in this case, and it showed growth of
Gram-negative bacteria.
negative organisms. Yeah.
Yes,
So so the other investigations were like this. Glucose fasting were 243.9. So clearly, if you see,
elevated.
elevated and critical to the diabetes criteria here. So post-prandial 2-hour glucose analysis, the hemoglobin A1C was also markedly elevated.
Again, what are the investigations? As well as he has this neutrophilia and hemochromatosis, and thrombocytopenia. Then we have this blood picture with increased WBCs, normal normochromic normocytic RBCs, and with reduced platelet according to the count. And for the biochemical findings, RFT is of normal range, but liver enzyme AST is increased, as well as CRP, which means there is acute infection, and as well as the culture shows growth of gram-negative bacteria. With these glucose parameters, it is looking like uncontrolled diabetes mellitus with acute infection.
Yeah, that's very good. That's a good interpretation to compile all the positive findings. Yeah. So we talked about pre-analytical issues with regards to glucose, with regards. Can you hear me?
Yes, sir.
Vials with regards to the dialytic variation also. So what about HbA1c? So HbA1c is actually a glycated fraction of the hemoglobin, and it is actually a non-enzymatic attachment of glucose to the amino groups of proteins. So it's a non-enzymatic. The keyword is non-enzymatic attachment. And the extent of glycation actually reflects the exposure of this protein to mean glycemia over a period of time. So obviously it tells you how the patient has performed over a period of time of approximately 60 to 90 days. Was the blood sugar in the patient? So it will tell you whether the patient has taken the medicines properly or not. Because sometimes the patient comes to the clinic seeing that the level of, and doctor says that the glucose level has not decreased even on oral hypoglycemic drugs. So he can actually see this HbA1c levels and tell the patient is non-compliant, because it will reflect the sugar over a period of approximately 90 days. So what are these recommendations with regards to HbA1c? So HbA1c should be actually routinely measured, usually every 3 months, until which is acceptable to the clinician. Individualized targets are achieved, and then no less than every 6 months in most of the individual with diabetes mellitus to document the degree of glycemic control. But there is problem with the estimation, and a major problem is in our country we have a lot of hemoglobin variants along with the diabetes population. So that actually affects the reading of hemoglobin A1C. So the ADA, the American Diabetic Association, has recommended that boronate affinity chromatographic assay methods are actually generally considered to be less affected by hemoglobin variants. So have recommended that in case of hemoglobinopathy, you may use this chromatographic assays to ascertain the correct degree of hemoglobin A1C levels. Right. So I have finished with the case 2 also, and this is the summary. So a man in the 7th decade came with neutrophilic leukocytosis and thrombocytopenia, which were deciphered from the CBC, which suggested infection. For infection, we did CRP levels, we did a blood culture, which were increased and positive respectively. The blood sugar investigations were in a diabetic range, and hence the patient was diagnosed as diabetes mellitus with infection going on in the body. And we also saw how hemoglobin A1C levels are to be done, and which are the points which can affect the hemoglobin A1C level, and how do you ameliorate those problems. So there is a short quiz with regards to what we have read today with regards to laboratory diagnosis of diabetes. So, which of the following confirmed values meet the diagnostic threshold for diabetes?
D.
D.
D, sir. Fasting
Very
glucose
good.
Fasting glucose more than 126.
Yes, absolutely. So D is the correct answer. Fasting blood glucose more than 126 milligram per deciliter, right?
Yes, sir.
The testing for checking mean plasma glucose concentration over a period of 8 to 10 weeks is?
Hemoglobin A1C.
A1C. HbA1c.
Yes. So A is the right answer. Then C in CRP comes from? Is it A, carbohydrate antigen of the capsule of pneumococcus? Is it B, carbohydrate antigen of capsule of meningococcus? Or C, carbohydrate antigen of the capsule of Haemophilus influenzae?
The pneumococcus. A.
A option.
Yeah, so I can see most of the people are marking A. I think they are taking the help of Dr. Google, I think. So, yeah, so CRP actually was discovered by Tillet and Francis in 1930. So the name CRP arose because it was first identified as a substance in the serum of patients with acute inflammation that reacted with C carbohydrate antigen of the capsule of pneumococcus. So it's the information which is good to know. And the fourth MCQ, microcytic hypochromic anemia is seen in all except copper deficiency, lead poisoning, beta thalassemia minor, or anemia of inflammation. I can see some are answering B, some are answering D. So copper deficiency actually causes a microcytic hypochromic anemia because copper will not allow iron to be absorbed. It interferes with the iron absorption. Lead poisoning is a known cause of microcytic hypochromic anemia. Beta thalassemia minor, again, it causes microcytic hypochromic anemia. Anemia of inflammation, which is also called as anemia of chronic disease, actually causes a normocytic normochromic blood picture. So this is the odd one out. And the last one is anticoagulant in a great top tube is?
Sodium fluoride.
Is sodium fluoride an anticoagulant? Sodium fluoride is? Sodium fluoride is actually a glycolysis inhibitor. It is not an anticoagulant. So that is the catch. I can see most of the people in the chat box writing A. The answer is sodium citrate is used in which tube? In a tube which is blue top, right, for coagulation studies. Heparin is an anticoagulant which is used for what? Any investigation have you seen in the heparin anticoagulant?
Prothrombin.
No. Prothrombin we do in sodium citrate. Flow cytometry can be done in heparin because it is more physiological and the sample can be stored for at least 3 days. So the answer is anticoagulant in a great top tube is oxalate. Fluoride is the glycolysis inhibitor and the anticoagulant is oxalate. Or if you see your tubes carefully, some tubes also have EDTA. So EDTA and oxalate both can be used as an anticoagulant in the great top tube. Right? So that's it. I think so. The great tubes contain potassium oxalate that binds to calcium, thus inhibiting coagulation. Another substance, sodium fluoride, is also contained in the tubes which serve as an antiglycolytic agent. So fluoride is antiglycolytic agent, and that is why it is used for plasma glucose and lactic acid testing. Thank you.
Thanks, Tushar.
Thank you, sir.
Students, do you have any questions? Are there any questions in the chat box for
Yes,
Tushar?
so there's one question.
What do we mean by point of care assay should not be used for the diagnosis in diagnostic criteria of diabetes, and also what is DCCT assay?
CCT is actually is a kind of body which actually monitors, which standardizes the test for diabetes mellitus. It's called Diabetic Control and Complication Trial, which actually I have not gone into details, but I can come back to you on this. Sorry. And the second question was.
What do we mean by the phrase that point of care assay should not be used for the diagnosis of diabetes?
Yeah, so point of care investigations are your glucometer,
Yeah.
which are actually not reliable. They are not standardized. So point of care investigations have to be corroborated with your routine investigations like fasting glucose, postprandial glucose, and hemoglobin A1C levels, or 2-hour OGTT test.
Tushar, can you stop sharing? Yeah.
Yes, sir.
Any other questions or comments for Tushar from the audience? Students, you have any questions for sir? Otherwise, Geetika can share.
There is a comment that the talk was very good and crystal clear.
Thank you, Tushar. Thank you very much. Tushar, I think we'll hand it over to Geetika maybe after half an hour, 45 minutes. If you're around, we can, if there are any questions, please join us after 45 minutes.
Sure. Yes,
Thank
sir.
You, yeah.
Yes.
Geetika, over to you.
Thank you, Dr. Sumit. I think I learned a lot as well. Dr. Shah, thank you for that.
Thank you.
So I'm going to move on now to show. Whoops. Share. Right. Okay, can you see my screen?
Yes, ma'am.
Yes, ma'am.
Yeah.
Right. So I think Dr. Tushar started us off on the diagnosis and sort of covered a few of the complications. For example, we saw a diabetic neuropathy with a patient with paresthesias, and then there was a diabetic foot with delayed wound healing. I am going to really take you through another major complication, which is diabetic nephropathy. But before we start looking at renal biopsies and understanding what's happening in the kidney, just a quick little revision of the different structures so that you can understand what's happening when we look at the slides per se. So I'm going to just randomly call upon some of our students. Dhanushri, can you unmute and tell me what is this structure?
This is the glomerulus.
That's the glomerulus, right? And can you see that this glomerulus has two poles? Something happening here. What do you think that is?
Forming the juxtaglomerular apparatus.
So not really. You can't see it in this. You're right. The JJ apparatus would be seen somewhere around here, although you can't see it right now. But this is the hilum. Okay. So the hilum, like we talk about in gross organs, right? The hilum is where the vasculature enters, and so the entry point for the vasculature or exit for the venous structure. So just as in gross, it's the same in microscopy. This is the hilum. This is where the afferent arteriole as well as the efferent arteriole will really come in and out of this glomerulus, right? What do you think this is, this area?
It's a vascular pole.
So this is our vascular pole, which I just talked about. That's the hilum. There you can see this vessel here. Can you see this vessel?
Yes, ma'am.
So what do you think this vessel is? So we forget this is kidney, just from your general path. What do you think this vessel is? You think it's an artery? Is it an arteriole or is it a capillary?
Arteriole, ma'am.
Perfect, right? So that's an arteriole. This could either be afferent or efferent. We can't really say on histology. And then that arteriole is going to open up, and these are capillaries, right? Thin-walled capillaries. That's forming the glomerular tuft. And the function of the glomerulus is, of course, to convert blood into urine. And then that urine has to come out from somewhere. And that's what you're seeing here. So just take a look at this. What do you think is happening here in this glomerulus? There is this epithelium-lined structure, which would be the tubule, correct?
Yes.
And therefore, this is known as the tubular pole. Okay? So this is just a nice picture. You don't see all the poles every time when you look at a glomerulus. For example, if you look at this glomerular cut here, you don't really see anything, right? You can only see one pole on this side, which would be the hilar pole. So we want to orient ourselves to where the hilum is, because when we start looking at mesangium, we need to be careful about hilar mesangium. And I'll take you into a higher power next. But can anybody tell me which stain do you think this is, this section? Yes, so it is AS, right? So what is the full form of PAS?
Periodic acid shift stain.
Perfect. So it's periodic or periodic acid shift stain. And we love to use this whenever we're looking at the kidney because it's a basement membrane stain. Like you can see here, this structure is the Bowman's capsule. It's nice and PAS positive. What is this structure here? This is basement membrane, right? And somewhere here you would also have GBMs, which is glomerular basement membrane, right? So what you see is that it is pink on PAS, which is PAS positive. So when we are going to look at our slides, what we want to know is something PAS positive or not? Immediately look for your nicely visible basement membrane, for example, Bowman's capsule, and decide is it PAS positive or is it not PAS positive? Okay. The other very good thing that we use PAS for is to highlight the mesangium. Mesangium is normally PAS positive. Let's look at it in the next slide. So I'm getting you closer into the glomerulus. And first I want to highlight, look at this nice PAS positive Bowman's capsule. And you look at this. What do you think this is?
Mesangium.
Right? That is mesangium. Okay. Mesangium is like a stop. It's what keeps those capillary loops together. Otherwise, everything would just dilate, excessively dilate. So you want to keep it together, and you have this sort of stop, and you will see multiple capillary loops emanating. You see, there's one capillary loop here. There is another capillary loop here, right? So let's see. Can you see more mesangium? That's mesangium. Yes.
Yes.
What is this? This is also mesangium. This is also mesangium. Okay. So the normal mesangium is PAS positive. You've seen what it looks like. It can sometimes have cells in it which are visible. For example, this is also mesangium, right? So the nucleus which is in the mesangium would be the mesangial cell. So that's the mesangial nucleus. We don't really see its cytoplasm because it's merging into the mesangial matrix. So this is the nucleus, and all the rest of this is matrix. Is that clear on this area? So you can see nuclei and matrix. But if you look around, sometimes you may not find a nucleus. Sometimes it just depends on the cut. Sometimes you'll see only matrix, here also only matrix, here also only matrix. Sometimes only one cell. So does anybody know that in each mesangial space, how many cells are we allowed to get, beyond which we would consider it to be mesangial hypercellularity?
3 to 4.
So more than 3. Okay. So I can see a lot of people in the chat box, 3 to 4. So we will allow 3. More than 3 we will consider as mesangial hypercellularity. So if you're clear on the mesangium, and then you can see the loops, I want you to observe what the loops look like. They are so pliable, right? This is what a normal loop will look like. So if you imagine like a tape-like structure which is moving, so you're seeing this, you're seeing it going along the edge, and then the loop will turn, and then you're seeing the GBM along its face. And I don't know if you can make that out here, right? So this is a normal pliability of a glomerular loop. So I was talking to you about identifying hilum, which is important because this is the hilum at the lower end of this glomerulus right here. And this hilar mesangium always looks hypercellular and expanded. Can you see? That's normal. So whenever we want to assess mesangial disease, is there any mesangial expansion, you stay away from the hilar mesangium, right? So if you don't know how to identify the hilum of the glomerulus and say, okay, this is hilum, I don't want to look at this. This is not telling me anything about whether this glomerulus has a mesangial pathology or not. Stay away from the hilum, right? The other important thing to remember when you're looking at any renal biopsy is the thickness of the section. So does anybody know how thick a section should be in a renal biopsy section versus what we do in other pathology areas? So a renal biopsy section is cut at 3 microns, and usual tissues, usual biopsies, any idea? It's 5 microns, right? The reason we have to go thin on a renal biopsy is that you are looking for things like mild hypercellularities. You're going to be looking at thickening of the capillary walls. So if I showed you a 5 micron thick section, everything would look hypercellular, everything would look expanded, everything would look thickened. You wouldn't be able to make out whether this is normal or there is a pathology. So in your centers, when you're looking at a renal biopsy, you should go back to your tech and make sure that you're getting a 3 micron thick section before you're actually assessing the biopsy, because otherwise you're bound to make mistakes. Okay? Now I've got some arrows here quickly so that we can get on to the cases. Can you tell me what these cells are? Kirtana, can you tell me, this arrow is showing us this cell here. What do you think this is?
Parietal epithelium.
Very good. Parietal epithelial cell. Is Sanjana online? Can you tell me, Sanjana, what this is? Okay, I can see somebody in the chat box. That is podocyte. Absolutely correct. Any other name for podocyte that you know?
Visceral epithelial cells.
Visceral epithelial cells. So it's so nice how you can actually get from gross to micro with similar concepts. Parietal peritoneum, visceral peritoneum, same concept. Okay, parietal epithelial cell, visceral epithelial cell. Okay, Devishri, what do you think this cell is? So this is the endothelial cell. How do you know this is endothelial cell? Can you see this is the capillary loop, right? That's the capillary loop. And you forget about this glomerulus. Anything which is lining a capillary is endothelial, right? And it's jutting into the lumen. It's jutting into the lumen. It is not surrounded by matrix. Okay, so this is endothelial. Right, where are my arrows then? Oh, I crossed this out, but you know what these nuclei are. We've already talked about it. So you've identified basically all the cells in the glomerulus, and I want you to note how the podocytes look like they're inside. Can you see? But they're actually on the outer side of the capillary loops. They're basically floating in the urinary space, right? These cells here are floating in the urinary space, and sometimes you get confused that this is hypercellular, but this is not hypercellular. These are all the normal complement of cells that you can see. Okay. Another stain that we really like to use, can anybody tell me what this stain is?
Silver stain.
Silver stain. Okay, but there are two types of silver stains that you use in pathology. Which one is this? Is this Jones or is this Grocott?
Jones.
Jones.
Okay, some centers do use Grocott sometimes, but Jones is always better when you're looking at kidney. Okay, and I want to show you this in high power just so that you get a feel of what is normal as we move on to the cases, right? You can make out the mesangium here also.
Yes, ma'am.
And you just see what the texture is. We call this argyrophilic. It sits on the blackish side. Can you see here? Right? That's the normal mesangial matrix. It's a little difficult to make out the nuclei here, but you can actually see them. The other thing that I want you to note is what the capillary loops look like in silver methenamine. Okay, look at them in the N phase, how clean they look, and then you see them this way as well, right? When you're just seeing it from the edge. Look at what they look like as they're twisting around in this glomerulus. Very clean looking, right? This is the tubular pole. So we really like to use PAS as well as silver methenamine. They are very good basement membrane stains. And you've seen the character of mesangium in both of them. Anybody knows what this stain is?
Mason trichrome.
Mason's trichrome. Okay. Mason's trichrome has a little limited utility in renal paths, but it's very useful in certain things. It's very good at looking for this material. What is this? Anybody? This is interstitium.
Interstitium.
Yeah, this is the interstitium, this is collagen. So collagen is very nicely highlighted in Mason's trichrome. And there are other materials which will get highlighted, like immune complexes and even hyalinosis. So, but this is in a normal kidney biopsy, we are highlighting with blue the interstitial collagen. So I'm going to move on now to the cases. And I think case 3, Dr. Devishri.
Yes.
So you've had a look at this case before, right?
Yes.
Could you quickly take us through the case?
So here we have a 48-year-old male, resident of Haryana, who is a supervisor. It's a known case of type 2 diabetes mellitus for 3 years on follow-up locally, and there are no records. Serum creatinine 1 year back was 1.25 grams per deciliter, no prior hospital admissions, and on oral hypoglycemic agents. He's also hypertensive for 2 years and on treatment with telmisartan for 40 mg per day, hyperlipidemia for 2 years and on treatment. No major hospitalizations, infections, or complications. The last available investigations, the urea creatinine is 38 to 1.5. HbA1c is elevated and fundus is normal, ma'am. No retinopathy.
If I just summarize at this point at baseline, before we get into his current issues, till now, what do you think he has? And this is a very common scenario, right? Diabetic patients also come with hypertension, metabolic syndrome. And do you think he's got some renal dysfunction?
Considering the serum creatinine 1.25 mg is high normal, I would say.
Slightly high. And how is his glycemic control?
Yeah, with poor glycemic.
Poor glycemic
control, 7.8 and 7.
Right. So let's move on. So his current issues?
He had come with complaints of headache for 2 weeks and frothy urine for 2 months. And the negative history of there's no fever, hematuria. Here the frothy urine is ticked again.
No, there's no history of all of these.
Yes.
Yeah, so forget about the frothy urine. Sorry about that. 2 months frothy urine is there. It's positive.
Yes. And there's no history of fever, flank pain, or hematuria, nausea, or vomiting. Considering the BMI, he's on higher BMI side with elevated blood pressure and normal SpO2. And bilateral mild pitting edema is a positive clinical examination.
Yes.
The systemic examination as well. The hemoglobin is low, considering it is 11. 13 above 13 is normal for a male, and the total leukocyte count is normal. Platelets are adequate. Sorry, the 1.5.
Slightly low, but that's okay.
And Here the creatinine is elevated, ma'am, 4.3, and potassium is also slightly elevated, ma'am, 5.2, and the rest are all in normal ranges.
Okay, agreed.
Considering the 3+ urine protein, it's high, ma'am, and RBCs there is hematuria. Urine protein is high, ma'am, 6.8, 6 grams per day is, and normal size kidney with normal ecotexture and normal Doppler. There is the corticomedullary differentiation is there. It's not mentioned, so I think the kidney here image based it is okay.
Serum protein electrophoresis is
This is
negative.
negative, and the autoimmune workup is negative for ANA and DSDNA. And C3 to C4 ratio is normal.
Yeah, so their individual values C398, C430, which is in normal range. Okay. So they planned a renal biopsy, right? So which clinical syndrome do you think this patient fits into from a kidney point of view?
AKI.
So why do you say AKI?
From 1.3 to 4.3, the jump of creatinine.
And along with that?
And along with elevated blood pressure.
Right. So the problem with the creatinine, I don't know if Arun is online to help us with this, but the 2022, so you have 1 year gap. Hi Arun, what do you think about
Hi, ma'am.
AKI on this?
Yeah, so regarding, hi to everyone. Regarding acute kidney injury, the definition specifically says that the onset should be within a week. So that is how it is. For 1 week to 3 months, it becomes acute kidney disease. So this is basically the day-to-day scenario what we see in a diabetic patient. Patient has some renal dysfunction or a poorly controlled diabetes a year back. He's not on follow-up. He has presented with uncontrolled blood pressures and renal dysfunction. So obviously we'll want to rule out the acute factors. So in the history, in the second slide, we have seen that we have ruled out almost all the acute factors. The common ones being infection, and if there is a acute onset of renal dysfunction, patient will have uremic symptoms. This patient does not have nausea, vomiting, no uremic symptoms otherwise. So in this scenario, we'll rather, and with a nephrotic range proteinuria, which usually does not happen in most cases of acute kidney injury, we would rather say it is a renal dysfunction under evaluation, query the chronicity because of diabetic nephropathy, or a superadded disease, non-diabetic kidney disease. That's what would be our differential. So because of we don't if we have had a renal function report in the last couple of weeks or last month or within 3 months at least, we can keep AK in the differential. Otherwise, we don't keep acute kidney injury in the differential.
Okay, so I hope that's clarified. And the problem is predominantly now that the patient has nephrotic range proteinuria. So how do you define nephrotic range proteinuria? Devshri? In the meanwhile.
Can you hear me, ma'am?
Yes, I can hear you. How would you define nephrotic range proteinuria? What's the cutoff?
More than 2 grams. More.
2 grams is it? So it is more than 3.5 grams in 24 hours. Okay. And the clinical syndrome, which is nephrotic syndrome, is not only nephrotic range proteinuria. Do you know what are the other components of nephrotic syndrome, the full syndrome?
Hematuria would be.
Do we expect hematuria in nephrotic syndrome?
No, it is nephritic.
That is nephritic, right? What do you expect in nephrotic? So accompanying this heavy proteinuria of more than 3.5 grams, we should get hypoalbuminemia, which would be associated with edema. And the liver tries to compensate, and as a result, there's hyperlipidemia and lipiduria. So these are the 5 components of nephrotic syndrome. So when we read a renal biopsy, before that, we do spend time in understanding what this patient has. And we would spend as much time as we've had just done right now to go through the clinical history in detail and understand the investigations. And you would have seen from the clinical history, there are a lot of things that could be hitting the kidney here. One, of course, is diabetes. There is also hypertension, right? And we are keeping in mind that there could be any other glomerular pathology which is resulting in heavy proteinuria. So as a rule of thumb, nephrotic range proteinurias, when you have heavy proteinurias, you are expecting that the problem is glomerular, right? And we are going to keep all those things in mind as we start looking at the biopsy. So I have opened up the PAS stain section again, and you can make out that it's a PAS because you can see that the basement membranes are all nice and pink, right? So I'm going to take you through this biopsy, and you can...
I guess we are not able to see the biopsy.
Oh,
Yes, ma'am.
yeah. So I will stop sharing and start sharing again. Now, can you see it?
Yes, ma'am.
Yes.
So let's look at this biopsy now. So if you're seeing glomeruli, that means we're looking at the cortex. Okay, if I go down here, you're seeing the other part of the renal parenchyma. What is this part? Devshri?
These are the tubules.
These are tubules of the medulla, right? So if you remember your gross anatomy of the kidney, you've got cortex, and then of course you've got medulla. And when the nephrologist goes in, they are really aiming to get a piece of both, little bit of cortex. You want mostly cortex, and you also want to get a little bit of medulla. So if you can see on the right side here, we actually have 2 cores of cortex, and this little bit that I'm showing you now is the medulla, right? So just to quickly revise what happens in the medulla will basically contain the loop of Henle, right? And then it will contain the collecting tubules, which are going down, right, to drain urine into the calyces. We don't try and make out the difference between these two when we're looking at the medulla, and the interstitium tends to always be more expanded. That is physiological for the medulla. So don't start counting this as either edema, and don't count this as fibrosis. Be very careful that you are not over-interpreting fibrosis in your biopsy by counting all of this that's happening in the medulla, okay? So we've identified the medulla, it looks pretty normal, nothing much happening, but we are now interested in the cortex. So we go back up and have a look at the cortex. Okay, so you saw what a normal glomerulus looks like, right? Now, if you keep that visual in mind, and now you are starting to look at these glomeruli. I will go into a little higher power. Can you describe what you're seeing?
I can see the Bowman's capsule.
Correct, that's the Bowman's capsule. Can you tell me what you think this area is?
These are the capillary.
So if you remember what I told you, you've got a stalk structure, and then these would be the capillary. Right? So if you're confused, if there's confusion, start from out and go in instead of starting from the middle and trying to figure out, okay? So you start from the Bowman's capsule, identified. Now you start going in and you will start seeing capillary loops here, right? And then you go in and then you see, okay, this would be the stalk area for this capillary loop. And this stalk area looks do you think it's
there is proliferation of mesangium here that we can see.
Right. Okay, so if we just count these cells, 1, 2, 3, 4, it's a little hypercellular. And what about the matrix? very expanded, okay, compared to remember what the normal glomerulus looks like. So you have an extremely expanded matrix, and you would think here that the matrix expansion is out of proportion to hypercellularity. So there is some hypercellularity, but matrix expansion is much more. So that's an important point to keep in mind when we're looking at glomerular pathologies. Is it more cellular, hypercellular mesangium, or is it more matrix expansion? Okay. So you definitely have matrix expansion, and can you see here also matrix expansion? Yes. What else is happening in this glomerulus?
Ma'am, I can see some capsular drop in the Bowman's capsule also in the adjacent glomeruli here.
In this one?
Yes, ma'am.
Not really. There's no capsular drop here. What we're seeing here is actually a little early Bowman space collagenization. This would start getting into sclerosis. But let me try and show. Show you on another glomerulus. They are there in this tissue. Let's see if this will focus. Slightly out of focus. Any other problem in this glomerulus? So whenever you are assessing glomeruli, like I said, go from out to in, and you describe all the structures. Okay. So you've seen the mesangium, you've described mesangial cells, mesangial matrix. Now you have to look at the capillary loops, right?
Yes,
These
ma'am.
capillary loops look patent and open.
Mm.
So what that means is that endocapillary hypercellularity is not there. If there was endocapillary hypercellularity, it would be full of cells. So my loops are patent and open. Then I need to talk about how are they thick? Are they looking slightly prominent and thick?
They are not as pliable as they were in the normal histology, ma'am.
Absolutely correct. Okay, they're looking stiff. So the term we use is stiff. They're not very thick like a membranous nephropathy. They are stiff, right?
Yes.
So we've got stiffening of capillary loops. We've got extreme mesangial matrix expansion with some mesangial hypercellularity. This is where we are. And they're starting to stick a little bit. Okay. So we've got adhesions to the Bowman's capsule. What is this structure here?
That's the hilum having the
Very good.
arteriole.
Right. So you've identified the hilar pole. This is an arteriole. And what's wrong with this arteriole?
I can see the hyalinization.
Very nice. So there is extensive hyalinosis. This is called intimal hyalinosis because it's on the intimal aspect of the arteriole. And it is concentric. So we would describe this as concentric intimal hyalinosis. Okay. So let's look around a little more. Right. So let's talk about this glomerulus. What's happening here? Let's try what do you think is happening in this glomerulus?
In this, we can see diffuse glomerulosclerosis, ma'am.
So
The capillary.
in kidney, when we are describing the pathology in a single glomerulus, we will use the term global and segmental, right? Global would be involving the whole glomerulus, segmental part of the glomerulus, okay? We use the term diffuse and focal when we're looking at the whole biopsy and describing proportion of glomeruli. Are most of the glomeruli involved? That's a diffuse pathology. Are few of the glomeruli involved? That's a focal pathology, okay? So we are dealing with a segmental pathology. You're absolutely right. This is beginning to sclerose. Sclerosis is basically, there's going to be sort of a collapse and retraction of the tuft and it's going to start collagenizing. Now this sclerosis is associated with accumulation of this material. Do you know what this is? It's very similar to the material that you saw in the arteriole. If you remember, look at this character.
Hyaline.
It's hyaline. Look at this character. Isn't it the same material?
It is, ma'am. It is eosinophilic acellular.
Correct. Glassy. That's what hyaline is. We describe it as eosinophilic, glassy material. That's hyaline. And then you come here and you see it's the absolute same material here. Okay. So some people may want to even call this a fibrin cap, which is basically a hyalinotic institutive lesion of diabetes, and it basically caps the capillary loops. Okay. So one institutive lesion is fibrin cap and the other institutive lesion is
Capsular drop.
capsular drop. And you can see a beautiful capsular drop over here.
Yes.
Can you see here?
Yes.
That's it. Capsular drop. Okay. And then we have the same issues happening. You're seeing very good mesangial expansion. You're seeing some stiffening of the capillary loops. We come here, mesangial expansion, stiffening of the capillary loops. Can you see this hilar arteriole? Same
Yes.
centric hyalinosis. Okay. So let's keep looking. This glomerulus is also looking similar. This glomerulus is also looking similar. Let's find some more glomeruli. Okay, let's come to this one. So on low power, what do you think this is?
Nodule.
There is a nodule, right?
Yes, ma'am.
So let's look at this nodule. So whenever you see this sort of nodular expansion, We have to describe it with as much as we can in all the stains. So let's just talk about this. How would you describe this nodule? First of all, location. Where do you think it's located?
It is located in between the capillaries, so can you call it intercapillary
Very good.
Mellitus sclerosis?
So it's an intercapillary mesangial nodule, right?
Yes.
And it is surrounded by these patent
Yeah.
capillary loops. Is it
There are-
cellular or acellular?
It is acellular.
It's an acellular intercapillary or mesangial nodule. So what do you think this is?
They are called Wilson lesions or intercapillary glomerulosclerosis.
Okay. If I asked you, why is this not segmental sclerosis?
Ma'am?
Why is this not segmental sclerosis? I get that question a lot when we're looking at these biopsies. How will I differentiate this thing from segmental sclerosis? This from, you just saw what you called segmental sclerosis. Let's see if I can find it. So can you explain why it's not segmental sclerosis?
Is it because
You saw one lesion here, right? This one you called segmental sclerosis.
yes.
Then you saw this lesion, this you said, no, this is not segmental sclerosis, this is a KW lesion.
Okay.
So what are your reasons?
Yeah, because the capillary collapse is seen in the other one.
Absolutely right.
Not in this.
Absolutely right. Okay, so a segmental sclerotic lesion is peripherally located. It will not have patent capillary loops. It would have collapsed capillary loops with collagenization. Okay, and it will always stick. It will always stick to the Bowman's capsule because that is what sclerosis is. So if you think about FSGS or segmental sclerosis is basically a scar. A scar forms every time there is loss of cells or tissue, right? That's basic definition of scarring. So what cell falls off and therefore scarring gets initiated? Which cell of this glomerulus, we've seen all the cells, which cells fall off and initiate sclerosis? Anybody? It's the podocyte. Okay. So when there is podocyte injury and that podocyte falls off, that gets replaced by a process of collagenization which produces scarring, and that is segmental sclerosis. So it's very clear, why can't segmental sclerosis be somewhere in the middle of the glomerulus? No, segmental sclerosis is going to be at the periphery because that's where the podocytes are. When they fall off, there's adhesion to Bowman's capsule and you have initiation of sclerosis. So I think we've clarified to everybody why this is KW lesion, right? Then you want to know what are its characteristics on the different stains. So we look at the PAS. How do you think it looks like on the PAS?
Your voice got cut in between, and can you repeat what you said again?
Sorry. So on PAS, what do you think is the nature of this expansion?
It would look dark pink.
Right. So we describe KW lesions as PAS positive.
Positive. Yeah.
But in real life situations, sometimes it is not very positive looking. Like here, I could argue, well, it's not as positive as the Bowman's capsule. So why that happens is because of initiation of secondary collagenization. Okay. But overall, KW lesions are PS positive. So is there any other lesion in the glomerulus in this case when you were looking at it? Or I think, have we covered all of them? So what are the additional features you always look out for since this patient has potentially maybe non-diabetic kidney disease also? So till now, everything that we've seen fits into a diabetic glomerulopathy. Do you agree?
Yes, ma'am.
And could you just summarize for us, so what are the features of a diabetic glomerulopathy?
Ma'am, we can see the hyalinization, diffuse increase in the mesangial matrix as well as proliferation of the mesangial cells. And then we can see the hyaline thickening of the arteriole. And then we can see the eosinophilic hyaline thickening of the parietal layer of the Bowman's capsule bulging into the glomerular space, which is called capsular drop. And you can also see the deposition over the peripheral capillary of the lobule,
which is called the fibrin.
fibrin.
Okay. So the matrix expansion, some hypercellularity, capillary wall stiffening, right? Then insulative lesions, which is fibrin cap capsular drop, and of course the pathognomonic lesion, which is the KW lesion. This summarizes what you've seen in these glomeruli, right? And we keep a lookout on negative findings always. It doesn't look like there is any endocapillary hypercellularity to suggest an overlying proliferative glomerulonephritis. Okay, you're not seeing any crescents, you're not seeing any tough necrosis, there's nothing else happening in these glomeruli. Now to corroborate your diabetic nephropathy diagnosis on this patient, after the glomeruli, you've checked the vessels, and the vessels also show you diabetic change. Do you agree?
Yes.
Okay, which is in the form of concentric hyalinosis. So we are left with one more compartment in the cortex.
Interstitium.
Very good. Interstitium and the tubular compartment. So what are the changes that we are seeing in this tubular compartment?
There's few tubular basement membrane show thickening in this.
Yes. Okay. So the TBMs of atrophic tubules appear thickened anyway, right? Even in non-diabetic patients, tubular atrophy is associated with TBM thickening. So the trick is to try and look at non-atrophic tubules. So first you have to know how to identify tubular atrophy, right? For that. So tubular atrophy, usual type tubular atrophy, the tubules look small, shrunken, with thickened and wrinkled tubular basement membranes. These are absolutely clearly atrophic tubules. Do you agree?
Okay.
Okay. So if I say that this is atrophic tubule, and then we come here, what do you think this tubule is? Atrophic or non-atrophic?
This looks non-atrophic.
Non-atrophic, right? Agreed. So the non-atrophic tubules, if you look at them, some of them are showing some thickening of the TBMs. So if I say this is normal, this is slightly thickened. Okay? So that also adds to your diagnosis that this patient has a diabetic nephropathy. Okay? So I will just try and show you in one more stain and then we move on. Okay, so there is definitely chronic damage with a lot of tubular atrophy. This is now the silver methenamine. So as the clinical history suggested that there is most likely has been a slower rise in creatinine over a period of a year, and it is accompanied with significant tubular atrophy. There is definite chronic kidney chronic tubulointerstitial damage. Okay, and I want you to note the nature of this lesion. This is our KW lesion. What does it look like on silver methenamine? It is black. There is some argyrophilia, right? So just like the mesangial matrix also, there is some argyrophilia in the KW lesion. Okay, but what is the nature of insudative lesions or hyalinosis on silver methenamine? They are,
They stay pink. They stay eosinophilic colony.
so they are non-argyrophilic, correct? So now when you look at it even on low power, KW lesion and mesangial expansion, which is silver positive, and now you look at all these hyalinotic lesions in the glomeruli, they are all silver negative.
Yes.
Okay, so the insudative lesions are silver negative. Can you see here? Right? Silver negative,
Next
silver
visit.
negative.
It points more towards glomerulosclerosis.
Or insudative lesions, your fibrin cap and capsular drops. Okay, so hyalinosis is always silver negative. The mesangial matrix expansion and the KW lesions will be silver positive. Okay, why is this important? Because a very important differential diagnosis of diabetic glomerular disease, which shows this mesangial expansion, is also amyloidosis, right? But amyloid on silver methenamine, what do you know what it looks like on silver methenamine?
Ma'am, it's negative, ma'am. It's negative.
Absolutely. It is completely silver negative. It will stand out as silver negative if it is amyloid. And on PAS, what does it look like?
Positive.
Positive for PAS, ma'am.
No, amyloid is
Negative.
PAS also weak. Okay.
On congruent, it is.
And Congo red positive. So this is how we would look at this biopsy. So if I just summarize for you, you have a good diabetic nephropathy, which is quite advanced. We will classify this as class 3. We'll look at how we classify it. And it is showing us very classical lesions. So you should be able to identify a KW lesion on a renal biopsy after seeing this. Okay. Now every kidney biopsy needs 3 investigations: LM, IF, and EM, right? You've seen the light microscopy findings. Now we move on to the immunofluorescence. I'm showing you a picture of IgG on IF. So can you tell me what's happening here?
Ma'am, here the glomerular basement membrane and the tubular basement membrane are positive for IgG.
And the nature of staining, is it linear or is it granular?
Linear stain.
Linear staining, right?
Linear.
So this
And I can
linear
see
staining in the capillary walls and as well as in the TBMs is very classical for diabetic nephropathy. Okay, and this happens due to non-specific adhesions of IgG, and you may also see it in the kappa lambda. Do you see immunofluorescence sometimes?
skin we do, ma'am.
Skin. Okay. So in a renal biopsy, this is what you're expecting to see: linear IgG in the GBMs and TBMs. And another good stain to highlight this is also albumin. So if you run an albumin stain also, it will show the same linear staining. And all you're seeing really is a non-specific sort of adhesion to these abnormal capillary walls. Okay. Then if you go ahead in the EM, what do you expect to see on electron microscopy of diabetes?
There is thickening of the basement membrane. 660 is very high, ma'am. Normal, we can take around 300 plus or minus 50 nanometer.
Absolutely. Okay, so you will see this isodense thickening of the glomerular basement membrane, which you are able to appreciate on light microscopy as that stiffened look on your basement membrane stains. And you may also see some mesangial matrix expansion. Okay, you will not see any evidence of immune complexes. So you will not see any electron dense deposits, and you may see some evidence of secondary podocyte damage, where the podocytes will efface and there will be some microvillus transformation. Okay, so this patient actually just had a diabetic nephropathy, And that diabetic nephropathy with the onset of all those segmental sclerosing lesions was enough for this patient to develop significant proteinuria. So that's the clinico-pathological correlation. Okay, so thank you, Devshri. I will just quickly take you through a little bit of theory. Diabetic nephropathy, it usually takes around 10 to 15 years after the onset of metabolic abnormalities. So a lot of times when you get your histories and it just says patient has been diabetic for 2 years, and you look at the biopsy and it's completely diabetic nephropathy, what's actually happened is he's been undetected for maybe a decade, okay, and then has presented within a very early period to have developed diabetic nephropathy. What's happening, of course, is it's a combination of these metabolic, hemodynamic, along with injury due to ROS, which is going to result in accumulation of advanced glycation end products, and there is going to be physically increased deposition, increase in the matrix, increase in GBM thickness, and all this accumulation results in both functional and structural abnormalities in the glomerulus, which is going to precipitate proteinuria. And we've seen a very, very advanced form of diabetes, but the earliest detectable light microscopic change is actually just a widening of the mesangium, best demonstrated with PAS stains. We must know about the Kimmel-Steele-Wilson nodule, which I've just shown you, the insurative lesions, the vascular hyalinosis, TBM thickening, and a complication of papillary necrosis. So how do we classify diabetic nephropathy? Class 1 is only actually identified on EM. It's very difficult to do this in India, and we usually will not get biopsies with a class 1 diabetes. Class 2 diabetes is characterized by diffuse mesangial expansion, and we divide it into mild and severe, 2A, 2B. Class 3 has the nodular sclerosis or the KW lesion, which we've seen in this patient, and you need only one. One good Kimmel-Steele-Wilson lesion will put the patient into class 3. And class 4 is advanced diabetic glomerular sclerosis, where you're supposed to see global sclerosis in more than 50% of the glomeruli. Okay, so let's move on to the next case. Kirtana.
Yes, ma'am. This is a 45-year-old male patient, resident of Haryana, occupation IT manager. He's a case of newly detected type 2 diabetes, detected 2 weeks ago, which is an incidental diagnosis while routine testing and initiated on oral hypoglycemics. No comorbid illness and no major history, hospitalization, infections, and complications. On clinical examination, the BMI is 24.5, which is normal. Pulse 80 beats per minute, BP 130/90, and respiratory 15 per minute, cycles per minute. SpO2 is normal. General and systemic examinations are normal. Hemoglobin, it is at the lower end, and total leukocyte count is normal. Platelet is again at the lower end. Blood urea is 46, and serum creatinine is 1.1. Sodium 139, potassium 4.8, calcium 8.1, and phosphorus 4.3. Total protein 6.5, normal, and albumin is also normal, 3.7. ALP is 272, uric acid is 4.6, and LFT, bilirubin 0.6, ALT 20, and AST 31.
So all okay.
Yes, ma'am. On urine routine, protein 2+, WBC 0 to 2 cells per cells, and RBCs present 4 to 6 RBCs, but no dysmorphic RBC. Culture is sterile, and 24-hour urine protein is 2 gram per day. And USG KUB, normal sized kidney with normal echo texture. And autoimmune workup, ANA and dsDNA is negative, and fundus, no retinopathy.
So we're going to have a look at the renal biopsy. So how would you sum up this patient's clinical?
Newly diagnosed diabetes mellitus case with proteinuria of 2+, and 24-hour urine protein will be 2 gram per day, that is non-nephrotic range, with microscopic hematuria, 4 to 6 RBCs.
And fundus is no retinopathy. right? So Dr. Arun will talk about that in a little bit, but there are atypical features here. And now the nephrologist is thinking whether this proteinuria, what is this proteinuria because of, right? He's only been diabetic for 2 weeks based on his history. This is always a problem with type 2 diabetics. It remains undetected for so long that you will not get an accurate history of when the disease actually started. So they want to do a biopsy and determine what this patient actually has. Can you see the slide now?
Yes, ma'am.
So let's go through the slide. What did you see, Kirtana?
I can see few glomeruli and tubules.
So is it only cortex or is it cortex and medulla? So first you identify the stain for me. Which stain do you think this is?
PAS, ma'am.
This is PAS. Okay, let's see. So then what stain is this?
This is PAS, ma'am. The other one is HMB.
Perfect. So let's come back to this first. So we have an H&E stain section which has only cortex. Okay. So whenever you're looking at a renal biopsy, start there. One core, cortex and medulla, only cortex. If you're very unlucky, only medulla, you can't really say anything. But this patient has a good core of cortex. So what is this? Do you need a closer look?
Yes, ma'am.
Anybody? Yeah, this is global sclerosis. Okay, that's a globally sclerosed glomerulus. So it's basically a ball of collagen. You now have a totally scarred glomerulus. Okay, so this is what we call global sclerosis. In the last slide you saw, in the last case we saw some segmental sclerosis. So I'll stay in 20x. Right. So what can you see?
Glomerulus with I can see the GBM and mesangial matrix is expanded.
Absolutely right. Capillary walls?
It is stiff, ma'am.
Stiff. This is the, what is this?
The arteriole, which is hyalinized.
Nice concentric hyalinosis, right?
Yes, ma'am.
Let's look at another glomerulus. This one?
Sclerosed glomeruli.
So there's something in diabetes when the glomeruli sclerose, they also show you a lot of hyalinosis. So those insulative hyalinotic lesions, you'll see a lot of them. So that's sometimes a soft pointer. But of course, you need to see good open glomeruli also. This glomerulus is similar?
Yes, ma'am.
Okay. So nice mesangial matrix expansion, much more matrix expansion than cells. Capillary walls appear thickened, right?
Yes, ma'am.
Okay. Same thing happening here. Yes?
Yes, ma'am.
And this glomerulus also. Okay. What is this structure?
There is thickening of the artery, wall of the artery.
Okay. So this is an artery. What is the expansion? Which layer of the artery is involved?
Tunica intima.
Intimal expansion. Okay. So it's intimal expansion of a larger size artery. And what is this usually related to? What is intimal expansion related to?
Hypertension.
hypertension. Okay, so this is usually an age and hypertension related change. And I just wanted to show you the same thing on PAS. Okay, so we've got some matrix expansion and some capillary wall thickening. So in this patient, did you see any KW lesion?
No, ma'am.
No, you didn't see a KW lesion. You've got the same chronicity in the background, yes? And you've got the vascular, glomerular, and if you see, you've got that again nice TBM positivity on the silver methyl on the PAS, right? It's much clearer on this patient. Can you see? These are definitely non-atrophic tubules with PAS positive thickening. So what is your diagnosis? What do you think this patient has?
Diabetic nephropathy.
Again, diabetic nephropathy. How would you classify it?
This will be grade 2, ma'am, since there is no KW lesion.
No KW lesion. Okay, so this would be a class 2B diabetic nephropathy. There is significant mesangial expansion. So I just put in this case to again highlight the changes. It was a nice morphology there, especially on the PAS. So thank you. We'll move on now. So if Arun is around, if he can step in and think quickly talk.
So once again, hi. So basically what happens is that the clinical conundrum what we have is when to biopsy a patient with diabetes. So all patients, or at least more than 1/3 of patients with diabetes, they are expected to develop some sort of renal involvement. And that renal involvement can be in the form of either proteinuria, significant proteinuria, or renal dysfunction, or a combination of both. So initially the thought process was that proteinuria has to be there for diabetic kidney disease to be present. But there has been multiple recent papers to suggest that there is a non-albumuric or a non-proteinuric phenotype, wherein patients will have only renal dysfunction without any proteinuria. So this just shows us that there can be multiple presentations of diabetes, and the most important reason why we biopsy a patient would be renal biopsy a patient would be that to see if there can be a change in the therapy. So for diabetic nephropathy patients, that is not going to be happening. So the only reason why we want to do a biopsy is to prognosticate the patient as to whether what is the degree of renal involvement already which has happened, and to rule out non-diabetic kidney disease, NDKD as we say it. So when do we suspect a non-diabetic kidney disease in a patient with diabetes? So usually retinopathy coexists with patients with nephropathy. This is true in all patients of type 1 diabetics. So if retinopathy is absent in type 1 diabetic, then we suspect a non-diabetic kidney disease. With regard to type 2 diabetics, nearly 60 to 80% will have coexistent retinopathy. So this means that we can have up to 40% of patients having a nephropathy-like presentation without retinopathy. So then if a patient is going to have a shorter duration, has a atypical presentation, and does not have retinopathy, then we go ahead with a biopsy, just like in the earlier case, the case number 5, in which patient had a short history, did not have retinopathy, and we went ahead with a biopsy. The third thing is proteinuria is expected in diabetic nephropathy. The degree of proteinuria can vary. It can be from a few milligrams to even more than 10 grams. So with the degree, we cannot tell if it is diabetes or not. So one, if the patient is going to have a sudden onset of proteinuria, like he does not have microalbuminuria initially, directly develops massive proteinuria, on follow-up we see that. If the patient has a very short duration of diabetes, or patient had a proteinuria of only a gram, but suddenly in the next follow-up after a month has a proteinuria of around 10 grams or 5-6 grams, then we go ahead with a biopsy. Microscopic hematuria to some extent is expected in patients with diabetes. If at all there is a macroscopic hematuria, if you have cast, then we go ahead with a kidney biopsy. Apart from this, if patient has any acute onset of worsening hypertension, which is not being controlled, because in that progressive diabetic nephropathy, the hypertension has to increase slowly. Patient will be on one drug, after a few months or years he will require 2 drugs. It will increase like that. If at all there is a sudden increase in the need for antihypertensive drugs, then also we should suspect a non-diabetic kidney disease. So this is in addition to the clinical features. Consider patient has some amount of any history such of connective tissue disorders like hair loss, arthralgia, skin rashes, then we go ahead with a biopsy. And most importantly, we should always get a drug history for the patient. most of the common drugs what we use like NSAIDs or even pantoprazole, which is commonly used or misused by most of the patients, can cause interstitial nephritis or other manifestations. And alternative drugs, be it homeopathic, ayurvedic or non drugs, they can cause any amount of interstitial involvement. So these are the conditions in which we suspect non-diabetic kidney disease, and this is where we go out with the kidney biopsy. So this article or this flowchart is something which is easy for us to remember. So if a patient with a type 2 diabetes mellitus has a suspicion of non-diabetic kidney disease, the first thing what we do would be to see if patient has retinopathy or not. If there is no retinopathy, and we then look out for the diabetic duration, and the duration is less than 5 years, then the likelihood of non-diabetic kidney disease is high, and we have to advise for a biopsy. If the duration is more than 5 years, then we see if the patient has a hematuria or not. If there is a microhematuria, then also the suspicion is high and we go ahead with a biopsy. If not, there is still a possibility that it can be non-diabetic kidney disease because of the absence of retinopathy and the shorter duration of diabetes. So then also we go for a biopsy. If the patient has a proliferative diabetic retinopathy, then the likelihood of a diabetic kidney disease is very high. In these cases, we usually don't go for a kidney biopsy at all. And if at all there is not a proliferative diabetic retinopathy, they have only a non-proliferative retinopathy, then we again assess for microhematuria. If it is present, we may consider a biopsy. If it is absent, we say that the patient is most likely having diabetic nephropathy and we don't biopsy. So overall, if the suspicion of diabetic nephropathy is high, we don't biopsy a patient. If at all we suspect any other disease, coexistent disease, in addition to diabetes or separately, that is the time when we go ahead with the renal biopsy and we trouble our pathologist.
We are very happy to be troubled, but thank you, Arun. So the bottom line was that if your patient of diabetes presents with some mild proteinuria with the retinopathy and everything seems to be typical, we would never get a biopsy. So every time you're getting a biopsy in a diabetic patient, you want to keep a lookout for actually additional pathologies. But today we wanted to talk about really the usual. So I've shown you more of diabetic nephropathy. Now, in the interest of time, I'm going to quickly move on to the last case. And in case 5, if anybody has problems, we can discuss it after this session. So I'm going to quickly go on to case 6. And I'll take you through the history quickly, and then we'll get one resident in to talk about the pathology. Okay, so this is a little twisted case. 64-year-old male who presented in June 21. He is diabetic for 10 years. He's hypertensive. And he has very acute symptoms when he comes in, up to even anuria. So he has decreased urine output, oliguria, anuria with some pain abdomen. And he has a significant history of COVID infection. So this was that COVID time. He had a severe COVID infection. He was given a lot of treatment for that, including remdesivir. He was put on steroids. He was in ICU for 20 days with this severe COVID infection in this diabetic and hypertensive. And when he came to us, he had a lot of significant urinary findings in the form of full-field pus cells, right? 100 to 120 just prior to a kidney biopsy. His kidney biopsy was required in view of this very high creatinine. This has not actually gone down. This patient had required dialysis and therefore the creatinine is reflecting as low. But he started out with a creatinine of nearly 9 and a lot of pus cells. So on the last case, I think we have Dhanushri. What does urine full of pus cells mean to you? What does that indicate?
Severe infection, ma'am.
Severe infection. So we're thinking about a UTI, right? And if a patient has pus cells in the urine suggesting a UTI and is associated with acute renal dysfunction, if you put it together, what do you think the patient could have?
Pyelonephritis, maybe.
Very good. An acute pyelonephritis. So, of course, clinically, he was from the clinic, he was sent out for cultures. And if you look at his culture studies, I think his culture studies were negative for fungal, negative for TB. And I don't see the bacterial culture on this, but his S-galactomannan as well as beta-D-glucan was negative, even though his fundus had this yellowish lesion suggesting a fungal endophthalmitis. So this was an important positive finding. What is your comment on his HbA1c?
On higher side, ma'am, indicating his diabetes is not under control.
He has very poor glycemic control. So, of course, the provisional diagnosis was an acute pyelonephritis on a background of diabetic kidney disease. So, can you tell us what you saw?
There is foci of sclerosis also seen, ma'am.
Okay, one globally sclerosed glomerulus. This is the Mason's trichrome. That's your globally sclerosed glomerulus. We need to take you to a higher power. So, what do you think this lesion is here?
Focal sclerosis.
So this is actually a very small KW lesion. Okay, and the reasons are the same like we discussed last time. There are patent capillary loops around it. Okay, so the confusion between KW lesion and sclerosis, you look if you have patent capillary loops. This is actually an intercapillary mesangial nodule. He also has a little mild mesangial expansion. So he is a patient who has diabetic glomerular disease. Okay. So we've established that there is diabetic nephropathy in the background. This is on an HNE. It's a very small lesion, but you can't miss it. It is diabetic nephropathy. But there is another problem. What is this?
WBC cast, ma'am.
Very good. Okay. So you're seeing these neutrophil-rich casts in the tubules. And what does that mean to us? When we see neutrophil-rich casts, it can suggest an ascending infection or evidence of acute pyelonephritis. Okay, so we've proven the clinical diagnosis. Yes, this patient has diabetic nephropathy. There is acute kidney damage associated with WBC casts, suggesting an acute pyelonephritis, right? And you can see this inflammation, including neutrophils, a lot of injury here. Now, luckily, in this patient, we got a good long core of medulla. This is definitely medulla. There are no glomeruli. And you can see something else happening here. Do you recognize what's happening? Let me take you to a higher power. So this is medulla, some tubular structures, an expanded interstitium, no glomeruli. Correct? Now you look at this part of the medulla. Is this area different from this area?
Yes, ma'am.
What do you think it is? So there is necrosis. Okay. So there is loss of hematoxophilia. You're not seeing the nuclear material. It's a very dirty looking necrosis. So if you put it together, you have the medulla. You have these two foci of necrosis, which are seen here. And this is actually a very rare complication. Nowadays, we don't see it at all. A rare complication of diabetes, which is papillary necrosis. Okay. So you have a diabetic patient with papillary necrosis. It's most likely precipitated by the diabetic state along with the severe acute pyelonephritis. But then we see something else. This is now the PAS. Can you see what this is? Let me get a closer look. Yes. So these are PAS positive yeast forms as well as, what is this?
Hyphen.
Budding. Are they true hyphae?
Pseudo-hyphen.
So these are budding pseudohyphae as well as yeast forms of, what do you think it is?
Candida.
Candida. Okay. This is now which stain? This is again a silver methenamine, but this is which type of silver methenamine? This is Grocots, right? So I showed you a Jones silver methenamine, which we use in kidney to show us basement membranes, and this is your fungal silver methenamine Grocots, and it also shows you the same thing. Nice budding pseudohyphae. So your final diagnosis on this patient was a diabetic nephropathy proven with that nice KW lesion with an acute pyelonephritis where you saw those neutrophilic microabscesses, WBC casts, a papillary necrosis, and a superadded candidal infection. And his fungal endophthalmitis would have also been the same. It must have been because of Candida species. Okay, that was just to show you a rare complication of diabetes. And like Dr. Arun talked to us about the non-diabetic kidney disease, just to give you a flavor of what else we see IgA nephropathies on top of diabetes. We can see post-infectious glomerulonephritis on top of diabetes. Okay. We see tubulointerstitial diseases like your case 5, which I've not discussed, was actually a drug-induced interstitial nephritis in a patient of diabetes who had taken some complementary alternative medicine. So you can see all varieties of pathologies in diabetes, but the most important thing, first of all, is to be able to identify diabetic nephropathy. And I've shown you in 2 cases very classical features of that. Okay, so I think that's all from my side. If there are any questions, I don't know about time.